Okay. Yeah. So first of all, good evening, everybody, and I thank the True team, Trichy Urological Education team, for having me on board. My task today is to talk about case selection in RIRS, more or less to see what are the cases you would indicate and which are the ones you wouldn't attempt in doing RIRS. So primarily, we'll be talking about when we're supposed to go ahead and do an RIRS, or when do we normally hold back, considering the fact that the advancements in ureteroscopes, like Tanuj was just speaking about, they're just going one place to another. They're getting more advanced. The flexibility, reaching different parts of the calyces, I guess, is no more a task, because the finesse of the scopes is so much that reaching a part of a kidney is not a task at all. Having said that, there are various other factors other than the advancement in the scopes or the way a flexible ureteroscope would behave to reach different parts of calyces. Those are, we should be primarily indicating based on clinical parameters, the stone size, the location, density of the stone, anatomical considerations, and of course, in some special scenarios where we would land up using a flexible ureteroscope. We'll go one after the other to see as to what are these factors they play a role in how we decide a case. Like we all know, any stone surgery, when you're posting for a flexible ureteroscope, you would want the patient to be clinically stable. There are no local signs of tenderness, which would primarily indicate a sign of pyelonephritis or maybe an abscess kind of a thing. So you wouldn't want acutely tender loin, and no signs of infection or sepsis preferably. And yes, again, when I say preferably urine culture negative, I will highlight on this point why I've said that it is preferably negative. And a red flag would be patients where there is loin tenderness, fever with chills, which are predominantly saying a big no, because those are the signs of pyelonephritis, tachycardia clinically. And when you do a laboratory investigations, again, of course, if the TLC is raised or a urine culture is positive, these are the strict no's where you wouldn't do. Of course, raised PCT is another parameter which is not done usually, but yes, when the patient is in sepsis, it is automatically seen that the PCT is also raised. When I said urine culture positivity as a relative or a probable contraindication, I'm going to quote a couple of articles where they say that factors that affect complication rate, like we all know, positive preoperative urine culture is something which we would normally wait on, maybe give a course of antibiotics and then take up the case. But having said that, there is another paper which comes out saying the risk factors of infectious complications following flexible uteroscopy. This is a place where you normally see a study where there are around 19 patients of the entire data who has landed up with infectious complications. And if you can see those red lines which I've made near urine culture, only 6 of them had a positive urine culture. Now that is one part of it. If you look at the blue lines, there are 208 patients who went home very safely without any complications. Yet, if you go down again, see the urine culture, there are 33 patients who had a positive urine culture. So as much as we say that the urine culture is positive is a contraindication, we also will land up in a situation where you treat them antibiotics with antibiotics, and repeat antibiotic culture might still, urine culture might still have a positive result there, but that doesn't mean that you have to hold back. So you'll have to assess both clinically as well as your urine culture to take a call on that. Coming to the stone size, I guess we've been seeing these charts for years now, and the guidelines are pretty much stabilized, and they are okay with a few parameters here. They're like more than 10 millimeter stone in the upper ureter or in a PUJ, you tend to do a ureteroscopy, or a flexible ureteroscopy or an RIRS is a straightforward option. But the true classification for whether we'll go ahead and do RIRS or not is coming to stones which are 1 to 2 centimeters, and especially the lower pole stones. And if you look at the guidelines here for stones between 1 to 2 centimeters, pretty much all of these can be tackled with an RIRS. As far as the lower pole stones are concerned, if it is more than 2 centimeters, that is when the question mark comes in, whether you would want to do a percutaneous lithotomy or you can still go ahead and do a RIRS. Of course you can, but there are a few features which you would want to be favorable for yourself before you attempt that. So the guideline says if the unfavorable conditions for a shockwave lithotripsy, if they are, then you go ahead and do a RIRS. But if they are favorable, do consider a shockwave lithotripsy. And of course, or endourology here means any of these modalities like flexible ureteroscopy or a PCNL. But as far as contraindication, if I might say, there are relative contraindications are renal stones more than 2 centimeters. But I guess the experts here would definitely not go with me if I say a blanket statement of more than 2 centimeters is a contraindication. It is not anymore. There are surgeons who are going ahead and doing stones for 2 to 3 centimeters because of the advancements in the ureteroscopes, the type of lasers we are getting in it. And of course, the more experience you get, the more confident you get that you'll be able to clear these stones. Hence, I have written there as a relative contraindication. But yes, stones like staghorn stones, matrix stones, infected ones, multiple calyceal stones where the load is, the cumulative burden is so large that you wouldn't want to attempt a flexible ureteroscopy. These are the ones for a strict no. But like I was just mentioning, when I say more than 2 centimeter stone is a relative contraindication, there are enough data and papers that are coming out now saying that flexible ureteroscopy is quite a successful option, even in stones more than 2 centimeters, like this one, with a good stone-free rate and minimal complications. And as far as location is concerned, like we all know, lower pole stones are the only ones which we're going to debate. The rest of the ones are a straightforward yes. But if it comes to a lower pole stones, again, the guidelines are split into 2 different schools of thought, one from the European school, the other one from the American. The European school of thought is like all the stones, like we saw in the guidelines, between 1 and 2 centimeters, it's a straightforward go for an RIRS. But if it's a more than 2 centimeter stone and an inferior calyceal stone and a lower pole stone, the first option still would be to do a PNL. But if the other factors are favorable for you, I'll come to that, what are those, you can still consider an RIRS. As far as the Americans go, there is another factor that comes in. More than 2 centimeters is straight away PNL. The less than 2 centimeter stones, the 2 more factors that they would like to highlight here is once the density of the stone, Hounsfield units, which is very, very important even in my opinion. And the stones which are softer, less than 1,000, and in the pediatric age group, you can still consider SWL. And there are stones which are harder, that are more than 1,000 Hounsfield units, the cysteines, and the more than 1 centimeters, along with some comorbidities, maybe you can still consider an RIRS. In summary, I can put it in a nutshell saying that the first line of treatment for stones, even if they are a lower pole ones, less than 2 centimeters, you can still go ahead and do an RIRS with some favorable conditions. But if the stones have failed on an SWL, even then they come down to your pocket of going into RIRS. This one parameter of Hounsfield units, I guess, as the days go by, we're all considering this to be a very important factor. Of course, it is, whereby you can actually plan your RIRS, whether you can actually go ahead and do it, depending on the location, depending on the density, depending on the kind of lasers you use. There are so many other things you should factor in before you say, yes, I'll be able to do this. And like I said, stones between 2 and 3 centimeters are also done these days as a primary indication. And this is a paper where they have compared larger stones with Hounsfield units as to how it actually plays a role in the end result. If you can see these 2 groups where patients having stones more than 1,000 Hounsfield units and the other group having stones less than 1,000, there's a significant or a clear-cut demarcation. If you see the ones I've marked with red, significantly the operative time is more in the harder stones with a success rate which is quite comparably less when you compare with softer stones. But I guess there are papers coming now which will actually negate the same data now with better lasers and more efficient scopes. And coming to anatomical measures, like we have been seeing all these things from day one of our medical school or maybe training in urology, that these 4 parameters, especially in urology training, we have learned, even for our PCNLs, are very important. The infundibular width, the infundibular length, the infundibulopelvic angle, and the pelvic calyceal height. So these are the 4 parameters, although unfortunately there is no one investigation which can actually give you all these details precisely. You should be able to keep them in your mind. At the end of the day, these are the angles which play a very critical role, whether you will be able to reach the stone or not. The pelvic calyceal angle, the axis of the lower polar infundibulum, and the uretropelvic axis. So if you look at these 3 lines carefully, eventually when your scope goes into the pelvis and tries to negotiate into all the calyces, these are the angles which play a major role. But there is another factor which I normally make a point saying that, which is very difficult to assess and there is no investigation which could give you, is the elasticity of the pelvic calyceal system on the tissue there. At times when you actually see a IVU or a CT where you feel the inferior pole or the calyx is very acute, you'll be surprised when you go in that it is actually very freely admitting. So that is another parameter which cannot be quantified but can only be seen when you go in. So the papers which quote about the pelvic calyceal anatomy and the success of RIRS, especially in lower pole stones, also say that if the infundibular length is less than 3 centimeters, and if the PCH, the pelvic calyceal height, is less than 2.5 centimeters, and if the infundibulopelvic pelvic angle is wider, more than 45 millimeters, your success rate automatically goes up. The converse holds good for lesser success rate. So these are the parameters which will give you a rough idea of how to qualify your cases. And of course, these are straight away issues or contraindications, or you wouldn't be going ahead doing in cases of narrow ureteric orifices, a narrow ureter where the caliber is less, of course, a narrow PUJ, an acute infundibulopelvic angle where the angulation is so steep that you will not be able to see the stone, nor even able to basket it, a narrow infundibular width. Of course, again, it won't admit your flexible scope, and of course, anatomical variations, which would again be tricky in some instances. Of course, not all of them, hence the question mark there. But if you still go ahead and see, you'll tend to see all these complications. I'll not go deep into the complications because that's not part of my talk, but you have to respect the anatomical limitations in doing flexible ureteroscopy or choosing your cases, or you'll end up seeing ureteric injuries like this, or hematuриas, or maybe even a perinephric hematoma, which is a dreadful thing for you. The infundibular injury, which is a tiny clip I'm showing, is the one where the infundibular width is narrow, yet you force your scope inside. It might go in, but look at the tear that happens at the angle. When you have the to and fro movement, you'll eventually land up with those infundibular tears. And of course, an acute angle of lower polar stone where you still go ahead and you'll see your laser fiber breaking within the scope, and that's a nightmare. You wouldn't want to lose your scope, nor you'll be able to finish your case. And of course, the most dreadful lot is getting out your flexible ureteroscope along with the ureter. That's once in a lifetime complications. I guess not one of us would want to see that. And flexible ureteroscopy isn't necessarily only for stones. The non-calculus indications are equally important, like for hematuria for evaluation, and upper tract TCC for diagnostic as well as therapeutic, where sub-centimeter upper tract lesions are used to treat by laser themselves. And renal papillary necrosis in diabetics, which is one thing which we at our institute do propagate, that after initial episode of pyelonephritis and we stent them, we normally get them back in 3 to 4 weeks time to do a flexible ureteroscopy to see if there are any necrosed papillae floating in the PCS. So that is one of the indications you can qualify for. And then of course an antegrade approach in post-urinary diversion scenarios. And this is the case which I was telling, that where this is a common scenario in our condition where a lot of diabetics we see in day-to-day practice, they'll have these necrosed papillae floating in their PCS. But we would normally pull out our stents and then send them home. But these papillae are just waiting there to come down and getting the ureters blocked. So we made it a protocol in our institute as to why not go in and see the PCS ones. There's no harm in seeing it. And you pick up if there are any floating papillae there. That makes your job easier in follow-up, and you're actually saving the patient an unnecessary second visit in the recent future. And of course, like I said, the upper tract TCC, where flexible ureteroscopy becomes a great tool for both diagnostic and therapeutic if it is a small lesion, not the one like in this. And hematuria for evaluation, like we all know, cystoscopy is part of evaluating an hematuria patient. Flexible ureteroscope also forms a significant role if there is an upper tract bleed. So it becomes a very useful tool there. And coming to pediatric ureteroscope, of course, yes, it is indicated in pediatric. It's a long gone debate now. And I guess our next expert, Dr. Chandmohan sir, will be speaking about in detail of pediatric flexible ureteroscopy. This is no longer limitations. Yes, we can go ahead and do flexible ureteroscopy in children. Having said the indications and a few contraindications also, but there are special situations in flexible ureteroscopy which makes our life much easier. And that's the beauty of having a flexible ureteroscope in your hand, like patients with bleeding disorders and patients like they might not be symptomatic, but professionally they would want their stones to be cleared. I guess now every one of you might be seeing these pilots and merchant Navy guys coming to you for a complete clearance. These are the scenarios where you can use flexible ureteroscopy very well. And of course, like in post-diversion patients, combined or ancillary procedures following a PCNL, anatomical malformations where you can use flexible ureteroscopy very well. And of course, in morbidly obese patients, and of course into pregnancy also in certain scenarios, flexible ureteroscopy is a real boon to have. And if you look at the guidelines also, the special considerations are also a part of guidelines, like calyceal diverticular stones, horseshoe kidneys with stones, stones in pelvic kidneys. These are all conditions where you have a flexible ureteroscope coming in handy, and it saves you a lot of trouble. It's very interesting to see even one of these papers saying that there are no specific contraindications for RIRS, which is a nice thing to listen, isn't it? As long as you know what you're doing. you could actually use a flexible uteroscopy in a very effective manner. And there are very useful nomograms coming in of late, although they are not widely used, like the one of RIRS scoring system, or the Ragoori stone score, it's called RUS score, or the Seoul National University renal stone complexity score. These are the few nomograms which give you a vague indication or a vague idea of if the score is on the lesser side, you are much safer and your stone-free rate are good. If the scores are towards the higher side, they are more complex and the chances of your stone-free rate might be a bit compromised. So to end with, what I would say is it's a permutation and combination of various factors that would actually matter in actually indicating or a contraindication in a case of flexible uteroscopy. As the technological advances are happening and we are adapting to it very fast, the technology grows, the indications are also growing, and the doctors are also getting very confident. The more you do, the more you feel better. So the indications start to grow, the more confident you are, and the contraindications automatically come down. Thank you. Thanks one and all for the opportunity. Thank you.